Thank you for the introduction, Chairperson. My disclosures. Although medication for RA has been improved by early intensive treatment using MTX and biologics, treatment of concomitant disease in RA patients, such as osteoporosis OP, will be more important to improve activity of daily living of RA patients. Appropriate treatment strategy for RA-OP is necessary. Although denosumab, DMB, an anti-LANC antibody was approved for the treatment of OP in Japan since 2013, clinical data in real world is lacking in RA-OP. LANC is the ligand of DMB and crucial in both joint destruction and osteoporosis in RA. RA-OP is composed of multifactorial pathogenesis such as excess of inflammatory cytokines, drug used for treatment of RA, especially corticosteroids, excess of rest due to joint pain, and influence of postmenopausal OP. The objectives of this study are to investigate the efficacy of DMB for 12 months on RA-OP and to find the predictors of efficacy at 12 months in DMB treatment using multicenter registry data. 64 female RA-OP cases treated with DMB for over 12 months were included in this study. LS-BMD and total hip TH-BMD were measured at baseline and every 6 months using DEXA. 2 serum bone turnover markers, P1NP for bone formation and TRAC5B and bone resorption, were also measured at baseline and every 6 months. The mean age was 69 years old. All cases were female. The mean RA duration was 16 years, and 24 cases, 37.5% were concomitant with oral prednisone. MTX was concomitantly used in 43 cases, 67.2%. 90 cases, 29.7% were concomitant with biologics. The mean flux was 26.4% and 43.8% of all had a past history of fracture. Our first result. Time course of BMD is shown. DMB treatment has significantly improved both LS-BMD and TH-BMD in RA-OP. Percent increase of LS-BMD was 4.3% at 6 months and 5.9% at 12 months. Percent increase of TH-BMD was 3.1% at 6 months and 4.0% at 12 months. BTMs were significantly decreased after initiation of DMB treatment and maintained until 12 months. Cumulative probability plots of BMD percent increase are shown. LS-BMD was increased in 91.7% at 12 months, and TH-BMD was increased in 90% at 12 months. Cumulative probability plots of BTM percent change are shown. BTMs at every 6 months were not decreased from baseline in all cases. P1NP was increased after DMB treatment in about 10% and overall, and the TRAC5B was increased in about 20% of all. Second result. Next, all cases were divided into 2 groups by the median LS-BMD improvement at 12 months, that was 4.9%. They are called good outcome group, GO group, and non-good outcome group, non-GO group. There are no significant differences in patient characteristics between LS non-GO group and LS GO group. Baseline P1NP value in LS-GO group was significantly larger than that in LS non-GO group, 62.5 versus 45.4%. Increase of LS-BMD at 6 months in LS-GO group was significantly larger than that in LS non-GO group, 7.6% versus 0.9%. Decrease of TRK5B in LS-GO group at 6 months tended to be large compared with that in LS-GO group. Next, all cases were also divided into 2 groups by the median THBMD improvement at 12 months. That was 3.4%. There were no significant differences in patients' characteristics between TH non-GO group and TH-GO group. Increase of THBMD at 6 months in TH-GO group was significantly larger than that in TH non-GO group, 5.0% versus 1.2%. Baseline LS-BMD in TH-GO group tended to be small compared with that in TH non-GO group. Baseline P1NP in TH-GO group tended to be large compared with that in TH non-GO group. Results of % increase of BMD in several DMB trials are shown, direct, freedom, and RA study group. Our results were comparable with results of DMB study published before. In conclusion, DMB treatment was effective in RAOP. BTMs at 6 months in all patients did not decrease under baseline values. These findings may be due to excess of lung over DMB in some patients. In other words, denolacking, denogire in Japanese. Larger baseline PNP and larger SBMD % increase at 6 months were the predictors of better LSBMD increase at 12 months. Larger THBMD % at 6 months was the predictor of better LSBMD increase at 12 months. Thank you for your attention.
So, any questions from the audience? Microphone.
Thanks. Interesting findings, but we know that TNFs as well as IL-6 can improve bone density. So I guess without a group with either of these agents, with or without denosumab, it's a bit hard to say how much of that improvement at 1 year is as a consequence of the better treatment of the condition with the TNF blocker as opposed to the effect of the rank ligand blocker. Do you want to comment on that? And did you correct for that in any way?
Sorry, I can't understand you. You mean denosumab with biologics treatment?
Because we know that the biological agents can improve your bone density,
yes,
improving disease, and we know they have an effect on bone and osteoclast and OPG. So how do we know what effect those agents had and what additive effect the denosumab had in addition?
There is no additive effect found by us, not yet. So now we don't see any additive effect by denosumab on TNF inhibitor or tocilizumab.
That's fine, thanks.
Thank you. Okay, no further questions. Then I think we move on.